all the amazing work that's going on, share it, to drive the commitment to both identify and support carers. So again, a warm welcome to you all. My name's Sian Harris, and I fairly recently, I don't know how long I can say this for, but I'm going to stick to it for today. I'm fairly recently new into the role of policy and strategy lead for unpaid carers at NHS England. And I've got some of the team with me today. So Ellie will be leading the Q&A at the end of the session and closing the session. We've got Steve here, who's going to give us the updates on which lunch and learns we have going forward. And we've got Hayley monitoring the chat function. So a huge thank you to all of you for supporting this. Just a quick through housekeeping. So as Hayley has put in the chat box, we are recording this session. So if you prefer not to have your face recorded, please put your cameras off. And if you could, as we do with all these things, if you could put yourselves on mute so we can listen to Morag clearly, please. We will have a question and answer session at the end, but if you have any questions that come to mind during Morag's presentation, please put them in the chat box and we'll pick that up a bit later. And then when we have a question and answer session, if you could use the hand function, that would be really, really good. So without any more from me, I would like to give a huge welcome to Professor Morag. I'm not going to say it. I did it really well on the practice and I'm going to let myself down dramatically this time. So I'm going to let Morag introduce herself. But essentially, Morag is going to come and talk to you about why and how the award-winning carer support nurse role was developed and the findings of an evaluation of its successful pilot in Great Yarmouth. So over to you, Morag, if that's okay.
That's fantastic. Thank you, Sian. And you did do very well on the practice run. It's a really tricky surname. I'm just getting my slides up. Just for those of you who weren't here right at the beginning when we were saying hello, I do have a cold. I apologise if I sound rather nasal, and advance apologies if I start coughing. It's very likely. So I have just downed a Lemsip and I have water beside me, but forgive me if I do splutter. I'm within reach of throat sweets as well if I need to suddenly get some. Okay, so let's save my voice for the important stuff. So thank you very much for this invitation. I'm presenting this work on behalf of a team which are listed here on the slide in front of me, from University of East Anglia, London South Bank University and University of Hertfordshire, as well as our PPI representatives. So I don't need to tell this group here who family carers are, what they do, what they prevent, how complex their lives can be, nor about the impact of the caring role on them. So I'm going to focus instead first on the rationale behind this carer support nurse role. So we know that carers have unmet health-related support needs. They have health-related education needs and may need specialist knowledge and skills, but often lack training to help them in their role. The caring role also negatively impacts carers' physical and psychological health, and there's even evidence of it impacting their mortality. There's many reasons for this, but in part it's because carers tend to put their own health second. They prioritise the needs of the patient. There can be ambivalence, but also it's just the reality of the caring role and the limited time they have to look after themselves. But it's also down to clinicians' limited time. Clinicians who are usually in patient-facing roles tend to prioritise the patient rather than the carer. This creates threats to carer sustainability, so the carer role is characterised by uncertainty and unpredictability, and carers are rarely acknowledged and largely unsupported by clinicians. This threatens carer health and patient support, which can lead and the patient. Oh, sorry, did I drop out? Am I back in? Okay, let me just start. I seem to have lost my sharing of my slides. Let me just get those going. Apologies, everybody. Okay, take me 2 secs. There's
Yeah,
nothing
I
like
think
a
you did just dip out for a couple of
just for a
seconds,
dip. It's
Morag.
classic. If I delivered this from home, this wouldn't happen. But because I'm delivering it from UEA, there's a dip. Okay, we're back on. So there is a health policy rhetoric that carers should be supported, but those policy documents rarely tell us how that should happen. And there's increasing evidence that caring is a social determinant of health. Carers can struggle to access adequate services and support. And this report from Public Health England identifies that different groups of carers can have different support needs and may benefit from additional support, which suggests that carefully designed interventions with clear pathways to impact and robust evaluation are needed. So our solution to this was to develop a carer support nurse role, targeting nursing skills within existing structures, but across systems. And it has two evidence-based prerequisites, one that it's dedicated to carers, and second, that it's a registered nurse. So it's dedicated to carers because of carers' known reluctance to bother healthcare professionals during what they see as the patient's time, and nurses' challenge in supporting carers within their patient-led roles. And it's a registered nurse due to carers' known unmet health-related support needs, both their own mental and physical health needs and needs in the caring role and the education and support that requires. So this differentiates the carer support nurse role from other roles, such as social prescribers or care coordinators. So it's filling a unique gap which was identified by stakeholders that requires nursing skills, complementing existing services. As one stakeholder described it to us, it's the missing piece of the puzzle for carers. So the carer support nurse was a one-year pilot funded by Norfolk and Waveney ICB, hosted in East Coast Community Healthcare, known as EC for short, based in Great Yarmouth and Northern Villages Primary Care Home Team, which is a team of nurses, therapists and social care staff supporting clusters of GP practices in the community. This was a collaboration between EC and UEA, which saw healthcare and academia working together to develop this evidence-based role and deliver evidence-based nursing practice. So in developing the role, we worked with over 70 stakeholders regionally across health, social care and the voluntary sector, and national leaders in carer support from NHS England, the QNI, Adult Social Care and Carers UK. But really importantly, we worked with over 100 carers and patients in developing the role, and there was universal enthusiasm for it. Locally, where the pilot role was based, carers in the Great Yarmouth area confirmed the national evidence about the need for the role. They told us they often felt their needs were not met, but instead could feel that assumptions were made about how they were coping. They could feel abandoned or passed around by services and could feel underappreciated and overlooked. They welcomed the idea for this new role, and they felt it could create a space for their needs to be discussed, provide opportunities to talk to a professional who understood how difficult it could be for them to open up about their own needs and would fill the gap in existing carer support. So there were 5 evidence-based design principles behind the role. First, that it's community-based. Second, that it used cross-sector working, so receiving and making referrals across health, social care and the voluntary sector. Third, that it delivers person-centred care to carers with complex needs. For example, by using the Carer Support Needs Assessment Tool intervention, CESNAT-I for short, which complements social care assessment and practice. Fourthly, that it would attend to marginalised communities. And fifthly, that it would be educational, both to carers and to other healthcare professionals by raising their awareness of carers and modelling best practice. So this was the carer support nurse at EC, Karen Murphy, who fulfilled the role in a 1-year secondment. She brought with her 5 years acute care experience and over 4 years of community nursing experience. The referral criteria that we developed were for carers living within the locality who have complex support needs relating to or impacting on their own health or well-being, or their skills or confidence to care, or unresolved health-related support needs that could not be met by their usual healthcare team. The really important thing in these criteria is that complexity lies with or relates to the carer rather than to the patient. So the evaluation of the pilot was led by UEA, University of East Anglia, funded by Health Education England, as it was now NHS England. supported by the NIHR Applied Research Collaboration for the East of England and UEA's Health and Social Care Partners. And as I mentioned on the opening slide, it involved collaborators from London South Bank, University of Hertfordshire, and our Carer Public Involvement Group. We had quite a remarkable advisory group for this project, given that it was an advisory group. I'm not going to read through all the names, but if you have a little scan down in terms of where people came from and their levels within those organisations, you can see it's quite an impressive group of people, which I think demonstrates the level of endorsement and interest from national leaders in carer support. So this was a pilot project, and it's really important to remember that it was a pilot. So it was trying to answer, is this even possible? Might it work? And how can we find out if it works or not, and how it works or not, rather than just simply, does it work? So it's leading to the way to a bigger project, which could really confirm whether or not it works. So it's a three-stage project. In the first stage, we explored how the role could work. So we identified local, regional and national carer resources that the nurse could use in her practice. And we ran workshops and interviews to operationalise the role with carers, health, social care and voluntary sector staff and a commissioner. So really working out how it might work on a day-to-day basis. So how she might deliver on those 5 evidence-based principles I showed you earlier. Stage 2 then evaluated the role and tested our evaluation methods. So Karen came into post in the middle of October 2022. There was obviously a period of policy and induction. And then once she was actively seeing carers, we were able to look at the value and impact of the role in terms of her role activity. We conducted a survey of carers to look at their outcomes in relation to health-related quality of life, well-being and preparedness for caregiving. We also collected qualitative feedback from carers and patients and feedback from health, social care and voluntary sector staff. And then the third stage of the study, we developed recommendations on whether and how to introduce the role elsewhere, what we learned about carer support and what we learned about evaluating the role itself. So I'm now going to give you an overview of the key findings. So I'm going to run through very quickly which types of carers did the nurse support, what did the nurse do, what was the impact of the role on carers, what were key stakeholders' views of the role as delivered. I'm going to just mention why it was a registered nurse and tell you about the resulting recommendations. Excuse me while I have a sip of water. Okay, let's start with which types of carers did the nurse support. Well, in the 9-month period that she was actively seeing carers, she received 124 referrals. About 3/4 of them were female and the average age was about 66 years. The referrals came from a range of sources across health, social care and the voluntary sector, but primarily from within EC, the primary care home team itself, so the colleagues she was working with. So as a group, carers identified who were referred to Karen identified needing more support across the full range of items on the carer support needs assessment tool, which underpins the CESNAT-I intervention I mentioned earlier as one of the interventions that Karen was delivering. What I just want to pick out on this graph, there's a lot going on in it, but was that the most frequently identified needs by these carers were looking after their own health, so their physical problems, and dealing with their feelings and worries. And this suggests that referrals were in line with the referral criteria and our stakeholder recommendations, which is reassuring. So what did the nurse do? Well, we have evidence that she gave direct carer support. So there was work around carer role acknowledgement and listening, about person-centered assessment and solutions using CESNAT-I, so opening up conversations about what was important to the carer and their unmet support needs, and then enabling solutions, so working together to respond to the carer's physical, social or emotional needs. She also carried out carer health screening and coaching. She upskilled carers in their role, and she assessed risk of carer breakdown and provided crisis management as required. And she identified and managed safeguarding concerns. But as well as directly supporting carers, she also provided advice to other cross-sector professionals. She delivered training. She was shadowed by other healthcare professionals to learn about her role. She attended multidisciplinary case conferences. She carried out role promotion through giving presentations. And importantly, she developed links with other organisations, and this became quite a feature of the role. So she had this extensive interprofessional, intersector networking going on across health, social care, the voluntary sector and emergency services, to the extent that she was often described as a super connector or a knowledge broker. And this was a role that was highly valued in her cross-sector professionals as well as in carers themselves. Now, this rather scary pie chart shows us that the proportion of activity undertaken by the nurse was distributed across different types of work and across what we call the nursing process. So through that process of assessment, planning, intervention and evaluation. And it shows the benefit of an experienced registered nurse being in the role. So it wasn't that she was having a chat or a discussion with carers and then signposting them, but she was carrying out a full clinical assessment and then planning and intervening as needed, in particular in response to the psychological needs of carers, as well as their physical and social needs. So in terms of where she carried out her work, it was primarily in carers' homes, which was really good to see. This was something that carers really liked and really welcomed, and something that she found was essential in order for her to carry out her assessments. So the third area I want to tell you about was the impact of the role on carers themselves who saw her. Well, there was overwhelmingly positive feedback from the carers. Really interestingly, referral itself was an intervention and had a positive impact before first contact with Karen. So just knowing there was someone out there who could support them with their health and well-being was important to them. The carers particularly valued opening up conversations, so sharing their experiences of being a carer and discussing difficult issues and feelings that they then felt enabled to share with other members of their family. They valued the practical support that was put in place. They welcomed the opportunity to re-engage with Karen if they needed to, but they did sometimes reflect that a more proactive approach, if it was a larger team of more nurses, would be really helpful. So carers really liked the fact that Karen was an experienced, mature nurse. As one carer said, she seemed to be a very good choice because she's obviously very experienced and, you know, she seemed to be able to cover everything as required. And this triangulates or matches with the activity pie chart I showed you, evidencing the nursing process and the benefit of an experienced registered nurse being in the role. This created psychological safety for carers to express their distress, and then for Karen to assess and respond to them with the carer using actions such as direct care or referral, as we saw in the activity analysis, based on her assessment. So one of our carer PPI members very helpfully suggested that we asked Karen which skills she felt had been priceless in the role when we interviewed her at the end of the pilot year. And she said, I think you're definitely looking at a senior. You need the experience. People value the experience. I don't think we'd have had loads of people opening up as they have done with me, with somebody who's fresh out of nursing school. You do need that life experience, that maturity. You need to have that. You need to be relatable. So this links back very well to the views of carers that it needed someone with maturity and experience to be in the role. So people are always interested in numbers as well as stories, and we often get asked, so what was the actual impact of the role in terms of benefits in improved outcomes, even though that's not the purpose of a pilot. The purpose of a pilot is just to kind of try it out and see what happens. So I need to share a little bit of that, those findings with you. So with the caveat that this was a pilot of one nurse in post for 1 year, using data collected over just 9 months on a small sample size, which wasn't designed to be big enough to answer this question, we did find a signal of improvement. So this is a small but non-statistically significant improvement in carers' health-related quality of life, mental well-being, and sense of preparedness to take care of the cared for person's emotional needs. But we can also say that any improvement or maintenance in outcomes is encouraging, given the vulnerability, the continuing caring trajectory, and the complex needs of the carers that were referred to Karen. So I'm just going to share with you the story of one carer. It's Susie. So Susie was carer to her mother for many years and full-time for the previous 3 years. Her mother had poor mobility, diabetes, chronic kidney disease, and she was deteriorating and had become bedridden. So Susie's role was to provide 24-hour care, so that overnight vigilance that's often required. She provided personal care, and she did have a background as a paid carer. She commented that she found herself being the information hub for everyone and could spend 2 to 3 hours on the phone every day, updating family. Before she met with Karen, she had some support from family and former colleagues in her carer role, but the district nurses she was in contact with, she considered to be for her mother only, not for herself. She was struggling with providing overnight care and struggling with her own health, and so she was referred to Karen by the district nurses who'd picked up on this. So what did Karen do? Well, she carried out a home visit, which Susie really liked. She really welcomed it, and some follow-up phone calls. And there was another phone call planned at the time we interviewed Susie after her mother had died in order to help with bereavement. Karen arranged for sit-in carers to work with Susie for the last 3 nights of her mother's life. And Susie said this helped her to get some sleep and to be less worried. When she spoke about Karen, she said she felt she knew where I'm coming from. She was kind, natural, asked what do you need, identified and acted on Susie's concerns about anxiety, palpitations, and an ECG, which needed sorting out. She also spoke about her just being there in the first place. The fact that this role existed was really important and made a big difference to her. So what she said was, it allowed me to be a daughter for the last 3 days of her life. When you're caring for somebody, liaising with healthcare professionals, dealing with her needs, you can't become a bit like a robot. If it hadn't been for Karen coming in when she did, I don't know what I'd have done. I was on my knees. She was just very kind, very natural. There was no sort of, I'm the nurse here to tell you what you've got to do and you do it. It was, I'm here. What help do you need? When she said, right, we've got someone coming in to sit with your mum tonight, I went, wow, I was able to get a bit of sleep, be more with my mum, sit with my mum, and not just have to worry, will she be all right all night? Susie then went on to describe a series of other actions Karen took in relation to her physical and mental health, and finished by saying, she made a big difference to my family's situation. If you want more proof that this scheme works, there's your proof. I want to share another quote from a healthcare professional talking about the indirect impact that Karen had on unreferred carers. So this community nurse said, having Karen's been an eye-opener. It's interesting, you forget about the carers, so it's highlighted that caring is a tough, tough job to do. It's good to highlight that. Staff have thought more about carers because Karen's been there. They've sort of like gone, oh, actually, yeah, and I've noticed in meetings, nurses bringing up patients and carers that if Karen hadn't been there, would never have been raised. So just to tell you a little bit more about what key stakeholders' views were on the role as it was delivered. So interestingly, when we asked cross-sector stakeholders at the beginning whether or not they felt there was a perceived need for the role, 9 of the 11 stakeholders we spoke to knew the role was needed before it even started, but 2 were a little less sure about it. However, they then reported very quickly learning of the need for the role once Karen was in place and they saw what she was doing. These stakeholders valued the role. They gave overwhelmingly positive feedback. The added value from this new resource was commented on, and as we conducted these interviews and focus groups at the end of the pilot, there was dismay that the pilot role was ending. We asked them whether they felt that Karen had managed to deliver on those 5 evidence-based principles that I shared with you at the beginning. They said, yes, she delivered on all of them and all remained relevant and important if the role was to go forward. But they did comment that attending to carers who are marginalised might need a little more time than a 1-year pilot in order to build up trust. So she'd made some inroads into this, but it was an area that takes much longer than a year to do so. They described a good fit with existing services, and they suggested some operational refinements that could be made just to make the role work a little bit more smoothly. So a stakeholder from healthcare said, I recently tried to refer someone through to Karen and was told, no, the service is no longer available. And I was gutted because there's very little else out there for the carers. There are voluntary organisations, yes, I get that. But this was specific for the carers to look at their physical and mental health and to offer education and support on how best to support their loved one at home. So I found that was a really effective role, and I'm quite lost without it, to tell you the truth. And then one more quote from social care. You don't really realise what you've got until it's gone. I've literally got a case come in half an hour ago that Karen came straight to my mind to give support to, which is someone who's newly in the position to give palliative care to their father. And what's quite sad is that they're already looking forward to the time when their father dies so that it doesn't have this impact on them. You get this. So without a shadow of a doubt, once Karen came, I thought, this is brilliant. I was really surprised that this was the only carer support nurse in the whole country. Yes, there is a need, 100%, somebody who is skilled to recognise certain responses to becoming a carer before it's too late. So we noted earlier that supporting the carer actually supports two people, the carer and the patient, but having conducted these interviews and focus groups with stakeholders who worked with carers, what we found was that supporting the carer through the carer support nurse role actually supports three people, the carer, the patient and the referrer. We had an additional source of feedback, unsolicited feedback from one medical practice that worked with Karen, who said, we've been very fortunate to work with Karen, and so far the difference she's making to our patients is incredible. Since December last year, she's seen 45 carers via various referral routes, which is the highest number of engagements for carer support over all practice areas. So this is very positive that we're going in the right direction to ensure that unpaid carers are supported. So working with our carer advisors, so our PPI group, we shared some anonymised carer interviews with them from the pilot to get their views and their direct reflections on the role that was fulfilled. And they were struck how the carer support nurse was able to sort things for carers, the connection she had, so this super connector role, her ability to help carers prepare and have headspace to think through their role, and her efficiency, so what she could actually achieve by being there in person in one visit. They also felt her experience and maturity was a key factor, as we've noted earlier, but like the carers themselves who were interviewed, they felt that the role could be more proactive if there was a bigger service, so if a team was in place. But what was really interesting was that these carer advisors felt there was a need to support Karen herself. So whoever is in the carer support role, there's a need to consider support for the role holder because of the emotional burden that they take on in the role. And that's certainly something that came through in our end of pilot interview with Karen herself. So I just want to reflect briefly on why it's a registered nurse in this role, because it's a question that we get asked a lot before I tell you about our final recommendations. Well, there are several sources of evidence in terms of why this is a registered nurse role. The first source is from the published literature. So the published literature tells us that carers have known unmet health-related support needs, both their own mental and physical health needs, but also their needs in delivering their caring role, so the health-related education and support that requires. And nurses have the knowledge and expertise to support carers with health-related support needs, particularly when they're complex, which is the type of referrals Karen was receiving. And that holistic nature of nursing combines need identification with physical and mental health assessment and support, self-care and case management at an expert level. The other source of evidence on this is from our stakeholder work. So stakeholders, which is carers, healthcare professionals, social care practitioners, commissioners and social care leads and professionals from the voluntary sector, advised that a nurse was essential for effective interprofessional working, which we saw through Karen's networking. And our carer PPI group told us that a nurse would increase the likelihood of carers' health-related support needs being identified and therefore addressed, and would give carers permission to express them. In terms of the evidence from the activity data we collected, well, we found activity of identifying and addressing carers' health and wellbeing needs, of anxiety and depression screening, of general health screening, of interpreting and responding to clinical data, of health coaching, of enabling carers to provide care through upskilling, supporting carers to choose and access health services, advocating for carers who felt unsupported or misunderstood by their healthcare team, and in terms of increasing other clinicians' awareness of carers. And then evidence from carer feedback within the pilot related to the creation of psychological safety that was mentioned, enabling carers to express their distress and then assessing and responding to it using actions from the nursing process. And I shared with you earlier about how this triangulated with actual data that we found in terms of the activity she was doing. And then finally, the final reason for it being a registered nurse is that this is a way of addressing inequality of care. It can reduce healthcare inequalities, ensuring access, support and treatment is delivered directly to carers. If we sought to identify and address the equivalent needs in patients, or to deliver an equivalent role to the carer support nurse to patients, we wouldn't question why this was a registered nurse or suggest it could be delivered by a volunteer. So we need to keep in our minds that carers are patients. They just also happen to be in a caring role, and carers themselves are marginalised patients. So what are our resulting recommendations? Well, we had 21 key recommendations. I am not going to run through all 21 of them for you, but I'll share with you where you can access our final report, which has them listed in there. There were 6 pivotal recommendations, which I will run through, and then the further recommendations related to establishing and delivering the role in practice, to organisational support for the role, to enablement of the role, and to future directions. So the 6 key recommendations that were pivotal were that the carer support nurse role is a mechanism for delivery on NHS pledges to support carers. The carer support nurse role should continue to prevent loss of the opportunity to move to it being sustainable and prevent loss of skills and established networks. It should be a team model which could maximise reach and should be led by a Band 7 registered nurse, potentially supported by Band 6 registered nurses. Those 2 evidence-based prerequisites for the role that I told you about at the beginning should remain. So first of all, it should remain dedicated to carers, and second, it should remain a registered nurse. The 5th pivotal recommendation is that an experienced registered nurse is recommended for the role, as the work that's carried out and is required is distributed across different types of nursing work and across the nursing process. So assessment, planning, clinical intervention and clinical evaluation, which, as we saw in both the activity analysis and in the carer and stakeholder feedback. But consideration should also be given to the relatability of the post holder or team members to the target carer population. And then finally, those 5 evidence-based principles that I shared with you for the role should remain, including the carer support needs assessment tool intervention as a core component of the role. So those are the 6 pivotal recommendations, but as I said earlier, there are some further recommendations relating to these other areas, which you can find in both the executive summary actually and the final report. Now, I'm delighted to say that the carer support nurse role was a regional winner in the NHS Parliamentary Awards in 2023 for the East of England. And we were also shortlisted for a Royal College of Nursing Award in the innovation category. So we were one of 75 finalists for the awards from over 900 applications. And I just wanted to share a final quote from Joyce, one of our carers, who said, "This is an essential role. I think it's a brilliant idea and I hope that it's rolled out." And these sorts of quotes are more valuable than the awards that we might be awarded. So in summing up, the carer support nurse is an evidence-based and came about as a result of the evidence-based and stakeholder identified gap in provision. Stakeholders felt and the evidence suggested that this was the right solution to try, and it was co-designed with those stakeholders using the evidence base and then operationalised with local stakeholders. The goal was to support carers with complex support needs relating to or impacting on their own health and well-being, or their skills and confidence to care through delivery of those 5 evidence-based design principles, and the pilot carer support nurse role achieved this. So if you'd like to take a look at the final report, the executive summary or the lay summary, so that these 3 different versions are available on this website. So there's a QR code which you can scan from your phone as well. These slides are going to be shared, I think, by Steve afterwards, so you can access that at a later point if you need to. What we're doing next is we're seeking funding to explore the role in varying localities now that we've had the success in one location. So if you're a locality who might be interested in this, please get in touch with me. We're hoping to conduct some commissioner workshops in May to find out what excites or concerns commissioners about the intervention, what outcomes they would like to see measured, and whether they're interested in partnering for a larger pilot. So again, if you're know any commissioners or you are a commissioner and you're interested, please get in contact with me. So we just finished with a call to action. Could this work in your locality? Are you interested? If so, please get in touch. And I'm so happy to jump on MS Teams and have a chat with people. And my final slide is just to give some acknowledgements to some very important people. So Norfolk and Waveney ICS, East Coast Community Healthcare, NHS England, the Applied Research Collaboration for the East of England from the NIHR, UEA Health and Social Care Partners, everybody who took part in the pilot and supported it, and our carer PPI group. So thank you very much. I'm really happy to answer some questions, and I will stop sharing now. And I didn't cough. Hey.
Thank you, Morag, for delivering such an interesting presentation. And as Steve has said there in the chat, the slides and the recording will be shared after today's session, so everybody will have access to Morag's detail and Morag's details and the link there to the final report and the QR code. I think really clear how the role, and it sounds like how possibly Karen in particular has had such a beneficial impact on the carers and also the partnership organisations and colleagues that you're working with. If it's okay with you, I'm going to jump to Hayley. I can see that we've got a lot of interactive stuff going on in the chat box. So if I could jump to Hayley to take questions from the chat box and just to capture anything that's come in that way, and then we'll go around to those of you with your hands up. So if you'd like to add something to either the chat or pop your hand up, we'll come around to you in that order. Is Hayley there? Just having quick.
Yeah.
Oh, you're there.
Hi.
Yeah.
Sorry, I'm just scanning through because I think there is quite a lot.
I think if I jump in early, the first one, I think it's from Fiona. Fiona, do you want to ask the question directly, or should I just ask what you've put in the chat box? It's up to you. You can unmute yourself and just ask the question. Yeah, there we go. You've muted yourself again.
Sorry, you do it, Steve. I can't remember what I wrote.
Let's have a look. I was just writing names down with people questions. So, I think it was just the presentation slides. So yeah, that's fine. We'll share the slides afterwards. That's okay.
I appreciate it's a lot of information, Fiona, that I delivered. So yeah, it's good to have the slides. You might also like to have a look at the report as well. So there's a lay version as well as an executive summary. The report itself is a bit of a beast. There's a lot of information in there, so it's good to start with the executive summary or the lay summary.
Thank you. Is it okay to share these with other people within my organisation?
Absolutely.
Yeah, great.
If your organisation wants to talk to me, put them in touch.
Okay, thanks very much for that.
Pleasure.
Thanks, Morag. And then we've got a question from Linda Hughes around referral criteria. So Linda's asked, how were those carers found and how wide was that selection?
Okay, so carers weren't so much that. Sorry, have we got someone with a microphone on? Is it possible just to? Thank you so much. So rather than carers being found and being selected, Karen did a lot of work at the beginning of the pilot, going around various organisations, letting people know that she was obviously there and in post. And because we'd done so much stakeholder work before she got into post, most people knew she was coming anyway. So that was good to have had that groundwork. And she was then able to share the referral criteria with them and generate referrals that way. And it was very interesting because when we were doing the original stakeholder work, there was a lot of concern that she might be overwhelmed, that there might be a flood of referrals to her because people had described this as the missing piece in the puzzle. And for that reason, we put in this made sure the criteria reflected the need to refer carers with complex needs. And we spent quite a lot of time trying to think about how we define complex needs. What do we really mean by that? And we went round and round in circles. So we thought, this is a pilot. Let's just try it and see what she gets. Let's see whether if we just put the word complex in, does this work? And speaking to Karen at the end of the pilot, she said it did. There was only a couple of referrals that she thought, this isn't really complex. You know, somebody else could probably have dealt with this quite simply. But because it was early on in the pilot, she just saw those 2 carers and gave them some support. But all the other referrals met the referral criteria well, as I think you could see from the support needs that were identified by carers who were referred. So yeah, it seemed to work.
And then there's a little bit of discussion around this in the chat box, but I'll ask the original question. So question around how the role differs from perhaps the support a staff member in a carer centre, for example, might provide.
So probably the key difference is I don't know whether those staff members are registered nurses. So if they're not, that's the difference. So she is providing nursing support. So she's a band 7 nurse. So this is specialist, highly skilled nursing support directly to carers. And one of the things that carers really liked about this was it meant that the nurse could deal with things there and then rather than refer on. Now, sometimes she did refer on, or she did signpost because she needed to, but most things she could deal with directly herself. And one of the frustrations carers had was being passed from person to person in order to get things attended to. So her focus was on health and well-being. So there are fantastic resources out there provided by the voluntary sector, also provided by social care in terms of other areas of support need. But in terms of health and well-being, having direct input from a registered nurse was seen as really important to the carers who saw her. They really valued it. And it was also highly valued by those who had referred. So those cross-sector stakeholders that she was working with. So when a social care professional referred to Karen, it was because they needed this carer to be seen by a registered nurse.
Fantastic, thank you. And then we've got a call from Danny around cloning a team of Karens. And there's some comments in the chat box there that echo that sentiment. Next question from Chris is around the size of geographical area that the nurse has covered. Chris says his area is very rural and he can see some challenges that might pose.
Yeah. So although I described it as Great Yarmouth, the actual patch she was in was called Great Yarmouth and Northern Villages, which I think it gives you a little hint in there. There was some rurality as well. So she was covering Great Yarmouth, but also this quite rural area too. And that brings challenges in terms of, particularly if you're doing home visits, it takes some time to get to those people's houses. It also can create limitations in terms of other services that carers could access. But it's a really good question because locality is really important, and that's why we want to do this study in some different areas. So we know it works in Great Yarmouth and Northern Villages, but we don't know whether it might work in an inner city area or whether it might work in an area that is completely rural, for example. So that's a reason for wanting to try it out in varying geographical localities.
Fantastic, thank you. And then last question from the chat box, and then I'll jump over to hands up because I can see we've got quite a few. So Heidi has asked, have you introduced GP resource packs in your area, sorry?
So I pass, I don't know on that. So I'm an academic, I don't know what they might have done clinical. I'm not aware of them. I don't know what those resource packs might include. So no, apologies, Hayley, I can't answer that for you, I'm afraid. I don't think there's anybody from the east of England on the call who can answer that for you.
That might generate a bit of chat in the chat box.
Okay.
if anyone's able to answer that. So
yeah,
moving over to hands up, Linda, I know you've been very patient. You've had your hand up a while there. Would you like to ask a question?
Very patient, Linda.
Yes, thank you. No, I'm listening intently. Can I say at the outset that this absolutely reflects everything that I think I and many colleagues have found amongst the carers that we support through our Carer Ambassador scheme here in Devon. And if you'd like to come to South Devon, we would welcome you warmly as a locality, please, to do stuff.
I'd love to come to South Devon.
Yes, please, we do. So all contacts there, can be found there. I want to add just a couple of quick things, if I may. I came a Carer Ambassador after looking after 3 relatives with a huge wide range of medical conditions. And when I came into that, through local government, who had the funding through local government to support care activities. And the very first thing I said was, and I only want to do it when it relates to medical matters. Why? Because carers are carers of patients, and therefore you cannot, they're inextricably linked. And therefore I can only do it up to a certain point. And it seems to me that one of the biggest divides that we've ever had is that the carer organisations, when it came in under the Care Act, initially concentrated very much on finances. So those who fell below a certain level and above a certain level of financing. That left a wide variety of hidden carers out of the loop, people who were just considered to be managing by virtue of the fact that they didn't attract that kind of funding, the self-funders as they call them. So I think that was an incredibly important part of the question I was asking about how we got to them. I absolutely endorse, because we were coming at it from a slightly different angle, which was a single nursing point of contact, which is what you're talking about here.
Yeah. Yeah.
We reflect that utterly. Thank you so much. But it's a nursing point of contact, not anything else. And about carers being seen as equal partners, which is something we try really, really hard to promote. And I just don't think, you know, what came out of it was just a coherent picture that utterly reflects what we have learned and have been experiencing for years. So thank you. Please come to South Devon.
My pleasure. Well, if you'd like to invite me, I'm very happy to come and talk to you.
Absolutely. Thank you.
Okay. Thank you, Linda.
I think there are several of us on the call that would like an invite to South Devon.
Yeah.
So if I could move the questions to Todd, you look like you're next.
Yeah, thank you. Thanks, Morag. That was great.
Pleasure.
I've got a sort of a comment as well as a question. So I don't know if, well, just to let you know, my day job, I'm a finance analyst in the east of England for NHS England. In addition to that, I chair the NHS England Staff Carers Network. So there's about 700 of us over the country. It's a national network.
Wow.
So first of all, we're here to help you spread the word. So if we can help do that in any way, we can.
Please, yeah.
From a personal point of view, before I joined the NHS, I was main carer for my mum, or around 10 years ago. And I don't know if I was a complex case, but I certainly would have benefited from a resource back. To give you my own experience, I looked after my mum in my own home for 2.5 years. In that time, I put on 2.5 stone and was eventually diagnosed with type 2 diabetes. I'm sure that with a little bit of support, that could have been avoided. So that seems to me the sort of thing that this is directed at. So
yes.
it really would have helped me. So thank you very much.
Thank you, Todd. Thank you for sharing that. And if there's any way I can connect with you to perhaps speak to your staff carer network, I'd be really happy to do that. So please drop me an email if that would be useful.
I will do. Yeah, there's already a message in the chat to say come along. We'd love to hear from you.
Okay, it's probably better that you email me if you're able to, because I'm not very good at looking in the chat. So
no,
I'll try though.
Fine.
Unless somebody shares the chat with me afterwards, could somebody do that from the team? That would be fantastic. Thank you. Thank you, Steve. Brilliant.
Did you have a question too, Todd?
I can't remember what the question was now. Sorry.
No, I can loop back to you if you want a moment.
Yeah, if it pops back. Oh yes. The question was to sort of I've forgotten the name of the previous person with the hand up. Was it Linda?
Yes.
Yeah. Add into the marginalised group, and you add sort of working carers into that group, because they're a group where they can be considered as being supported and being able to cope, but there's a lot of feedback from our own members that that's not the case, and that they do need support.
Yeah, absolutely agree with you. Totally agree. Yeah.
Thank you, Todd. So just 2 more questions then. We have Danny, I believe you were next in the line.
Yeah, thanks. I think it's great what Karen does, and I completely get needing an experienced, mature nurse to do it. I think that's brilliant. At our carers organization in Cumbria, so if you ever want to come up to Cumbria and see the lakes, we're here.
Definitely. Yeah, one of my favorite places. Yeah.
Yeah, we do the softer things. We do the assessments, the support plans, we signpost. If we take out, if a carer needs something doing that we can do, we either do it ourselves or we find the answer or the support that enables them to do it or answer their question. Our biggest frustration is when the cared for is in hospital and the carer can't get hold of anybody, doesn't know what's happening, and is stressed unbelievably. We've had so many discharges that have gone completely head tits up.
Yeah,
you know,
yeah.
where the cared for is back in hospital within 24 hours. And in a lot of them, if somebody would have been there to explain what was going to happen, what was going to be expected, how reablement worked,
Yeah.
it could have diffused the situation. So that doesn't need to be at a Karen level. I think you need the Karens, but I also think you need somebody sitting in the transfer of care hub, as it's called up here, to get in touch with the carers and explain, or talk to us and we can explain. But so much stuff goes wrong at that point, and it doesn't need to, and there's so much stress caused. So that would be a plea to look at that as well, please.
I would agree. I am aware that there are discharge coordinator roles who do look at carer support, but I think the problem with a lot of these schemes, including our one, is that they're often, you know, dotted around the country. Nothing is consistent. Even when we know that something works, we don't introduce it across the NHS, and that's the real battle. Carers are always the ones on the back foot. They're never put front and centre, and I think the NHS is missing a trick, frankly, in terms of not supporting carers.
I agree with you completely. Like, our trust is the North Cumbria Integrated Care Trust. Across the hill, we have Cumbria, North Tyne and Weir, and they have carers leads in every single department. You name it, they've got a carers leads.
Right.
They took over in the Cumbria Trust the learning disabilities, mental health, and elderly dementia services. So in 3 areas of that hospital building, you have carers leads.
Yeah.
And the other departments of that hospital don't know these carers leads exist because it's not their service. And you just...
yeah, you couldn't make it up, could you?
No, not at all. Thank you, though.
Yeah, no, completely agree with what you're saying. I personally think that there's a role for carer support nurses in all sorts of different localities, but I'm obviously slightly biased, but yeah.
Yeah. Thank you, Danny. And then last but certainly not least, Margaret.
Margaret, you've been very patient.
And actually, I mean, mine question stroke comment similar to Danny's. I mean, I was a primary carer for my mother for a number of years. She died a couple of years ago. But for another number of years, I've been the primary carer for a son who has had several hospital admissions with, he's got an ongoing mental illness. He's doing okay at the moment. He actually works in the NHS. But the differences I've found between, and they were both in South London, between physical health services and mental health services. Mental health services, I think, as a carer, the biggest help carers need is navigating the system. And we now get more help from each other. We've got a big like carer WhatsApp network than we do from any of, like, there's a local carer service in Lewisham, but they're I don't know if there's anyone on the call from them, but we've got in Lewisham a big WhatsApp group for specifically for mental health carers, and we get more support from them than we do from anybody else, because so many of us have become, unfortunately, experts by experience. And that the biggest help you need in mental health services is navigating system and knowing what's going to happen next.
Absolutely. Absolutely. I couldn't agree with you more.
I don't think you had any mental health carers as part of the project, did you?
No, we didn't have anyone where the primary diagnosis of the person being supported was mental health. We didn't. Partly that was because there was a provision for mental health support by a nursing team, for carers of people with mental health support by a nursing team slightly to the north of the area. And I think that's probably why we didn't get any referrals for Karen in relation to mental health. But I completely agree with what you've described. I mean, I myself am a carer to a family member with a mental health problem, and I've experienced the same thing as you. The other thing that I experienced, which may resonate with some of you, is that I watch the person I support fill in a form for a healthcare service. And one of the questions on the form was, do you have a carer? And I watched this person tick no. And in my head, I'm screaming, hello, I'm here. I'm the person who's supporting you at home. So it's not just about how we support people, it's about how we identify carers as well is really important. And that's true of any service. It's not just mental health. So the word carer doesn't work for everybody, does it? Because, you know, this member of my family certainly didn't recognise the term and understand what it meant.
And I think also another issue for carers of mental health service users in some areas of the country, and I'm thinking specifically South London, the mental health services aren't part of the ICS. They're a partner, but they're not part of the ICS.
Oh, interesting. I didn't know that.
Yeah, so you've got South London Maudsley Mental Health Services, and you've got the Southeast London Integrated Care Board. And although they're partners, there's very little communication between the two. So when someone is discharged from somewhere like the Bethlehem, and they're being transferred back to you know, their local services, communications are appalling. Yeah, sorry.
That's a problem. Yeah, that's a problem. That's a problem.
Yeah.
Thank you for sharing that,
Anyway,
Margaret.
sorry, that was my rant for the day.
No, and thank you.
It's good to rant.
Thank you for sharing your experiences. Also, Margaret. I think that looks like we're at time. So all that brings me to do is to thank Morag again for that really interesting presentation and the lively discussion that it's ensued afterwards. And to thank you if you've spent your lunch hour with us today. So the next, I'm just looking at the chat box there. Thank you, Steve. The next session, if you want to make a note, is on the 29th of May from 1:30 to 2:30. And that is awareness tools for identification, including asylum seekers, refugees and young carers. And that will be delivered by Newcastle Carers. So thank you again for your time. I think you've got about a minute and a half back. Just go and make a cup of tea before anyone's next meetings, which is always a win. Thank you. See you soon.
Thank you.
Thanks, everybody.
Bye-bye. Bye.
Thank you.